Sir, his neck is quite stable. He himself is lifting the neck.
Yes, sir.
आता त्यांचं लेक्चर संपलं.
Yes, sir. Negative history, there is no bladder bowel involvement, no fever, weight loss, no previous history of a neck pain prior to trauma, no multiple joint pain.
So with this type of history, what is coming to your mind? Sometimes the examiner wants to know what is your historical diagnosis. You have built up a story. In which direction is it leading us? Or what are the possibilities in this type of history?
It is suggestive of a cervical myelopathy. Due to acute disc or degenerative. Maybe due.
What you mean to say cervical spondylotic myelopathy?
Yes, sir.
Cervical spondylotic myelopathy.
Yes. No. He is not able to sit even without assistance.
But the deficit is still increasing. According to the history, you must have examined only today, so you may not be in a position to say whether it is increasing or. But he says that gradually it is worsening with time.
Yes, sir. It is working.
So how will it worsen in a condition which is slowly evolving and then worsening with time? Which direction is it leading? Over a period of 1 month or so, it is gradually deteriorating in the neurological status.
Yes, sir.
I think you need to be very clear in your presentation. The way you presented the history and then the way you concluded, what is it? Acute disc or chronic degenerative? Totally contradictory. This is not the age group for an acute disc. This is not the way it progresses. This is not the way it presents. A chronic degenerative condition in an elderly person, again most unlikely. To say that most unlikely. Trauma, you said started with trauma of a weight. Neurological. More you examine it. I'm just saying, when you're presenting a history, what is your diagnosis based on history? You have to justify it. It has to be a chronic condition. You may
Normally it is possible that you have grade 4 in upper limb, lower limb, and then you can become 3 and 2. But contralateral increase in the power, motor power.
It is a so it is like it is but what we see that
extra will be what?
And past history. There is no past history of a tuberculosis, diabetes, hypertension. There is no past any surgical or medical illness. Alcohol.
might say
नहीं आता है
ये इलाज क्लोज
So normally में they close get otherwise when they normally Just one retention overflow में भी आता है. That is why what I want to convey to you that you have to really go in detail.
Because all of us feel that in a patient who is gradually evolving quadriplegic, it's likely that there may be some component of bladder involvement. It may not be there, but we have to provoke and ask targeted questions to absolutely rule out bladder bowel involvement. That is our aim. If it is not there, it is still fine. Any significant finding in the general physical examination? Want to say? For specific general physical examination. Some important negative finding you can say that is not there, which is relevant in this case, not for the sake of saying, but specifically negative findings. Just think of that and think about general physical examination.
See, in the history also, when you're taking history, you should also exclude possible primaries, prostatic and thyroid and other things that you should always check. When a patient is presenting with something like quadriparesis, you look at the respiration. Is it abdominal thoracic, or is it thoracic? Example, supposed to check that. First, it becomes important suspicion because these are you expect some of these people because the sympathetic. So these patients in general examination, you think it is not important. This patient becomes important because they have they have abdominal.
I also. Also.
You must look for these.
Can you tell? What is normal respiration? What is the normal respiration? That's normal. तो फिर क्या होगा? Abdominal respiration होगा.
Somebody simple 30 we are asking. The audience can also answer that.
Often observed residents when you probe them.
Anyone want to answer? This is a normal respiration. What is abdominal respiration? What is normal respiration? What is abdominal respiration?
This is 30 minutes. The thorax expands. What happens? When you take a deep inspiration, your thorax expands. And when the diaphragm is so, or getting it down, isn't it? It's going down like that. And when you're expiring, the thorax is shrinking in. In predominantly thoracic respiration, which is normally the normal case. Thoracic plus abdominal, you have the diaphragm contracting with, it has to rise up to expel your, every time it has to rise up. When the diaphragm rises up, there is negative pressure in the abdomen. The abdomen goes down, it's tucked in. When your inspiration is there, the diaphragm is relaxing, descending, and the abdomen is going up, the abdomen expands. It's not after that. When you have a reverse happening, when only the diaphragm is working, the chest is not expanding. So then what happens? Your diaphragm, with every contraction in the abdomen, so predominantly only when the patient has to breathe out, he has to tuck in his abdomen to expand, and to breathe in, he has to tuck out his abdomen. So it is a reversible expiration movement that is happening. The abdomen has to expand in to increase the capacity there. So it's a reversal of the normal procedure which happens. If the diaphragm is paralyzed and only the chest muscles are working, then again it's a paradoxical movement which happens. When you exhale, the abdomen tucks in. When you inhale, the abdomen goes out. So it's a completely reverse movement that happens. So when you are actually breathing in with only chest muscles, the diaphragm gets sucked in. If it is paralyzed,
intercostal muscles.
it's only the intercostal that is muscle working. The diaphragm gets in, there is negative pressure, which is normally not the case. When you're inspiring, the diaphragm gets pushed down. So it's a completely reverse movement. It's a paradoxical respiration which happens when the diaphragm is not working properly. When you have diaphragm paralysis, when you have phrenic nerve paralysis, every time the person inhales, the diaphragm gets pushed up. So that's a practical problem that happens. And when the person is exhaling, your abdominal pressure rises because of a completely contradictory situation. So you need to be very clear on this. Normal breathing, abdomen and thorax works in synchronicity. In diaphragm paralysis, when you inhale, the diaphragm doesn't rise up with the movements of the chest. Normally it doesn't rise up. So you need to be very clear on this.
What is the root value for the diaphragmatic nerve? This nerve which supplies the diaphragm, phrenic nerve? 3/4. And intercostal muscles will be lower than that. So often the diaphragm may be the only functioning thing, and the intercostal muscles may have paralyzed in a cervical lesion. That is why he is surviving.
So the abdominal excursion is completely reverse of the normal excursion when the diaphragm is paralyzed. Is it okay? That's a thoracic respiration. Only the thorax is working, abdomen is not working.